So I think this has been a kind of a debate for many years. I think this stems from some of the PVSG studies earlier in the mid 1900s that have shown that although cytoreductive agents given to patients may have reduced the thrombotic risk in the first few years of the disease course, that later on some of these leukemogenic agents used then would cause leukemia. And so those earlier studies have sort of paved a path to the current management paradigm of PV, where the management tends to be more conservative for young patients due to concern that the treatment given to those young patients over a long period of time would promote the progression of disease to leukemia. So I think that those fears have been kind of embedded in the clinical practice of polycythemia vera treatment. And I think that's an issue because certainly we don't use those leukemogenic agents anymore. And when we think about young patients with polycythemia vera, we think about treatments like interferon alpha, which have a track record of safety. Look, every drug has side effects, but the treatment of interferon has been shown in many, many studies to be safe overall long term, and we have, in our experience, used it to treat patients who are younger or older. And so, our paper about excess mortality in young MPN patients was done to highlight something that I think we're missing, something that patients who are generally considered low risk because they're young are still at high risk of death compared to their compared to controls, people of their same age who don't have PV or MPNs in general. So I think highlighting the fact that the young patients with MPNs have an excess mortality on the long run, and their life expectancy is shortened by their disease, begs us to start thinking about how to intervene early to prevent that excess mortality. And so, compared to older patients to their peers, younger patients have even higher excess mortality. And so that, again, kind of brings us back to think about how do we intervene early using drugs that are not known to be or are really not leukemogenic like the drugs that were used a long time ago. And so interferon really fits into this picture because it's not a leukemogenic drug, and because it's one that we have shown to potentially prolong survival, at least in polycythemia vera. And so perhaps the new paradigm in treating young patients with MPNs is early intervention, early diagnosis, detection, and early intervention. Currently, the drug of choice, in my opinion, for early intervention would be interferon. But of course, I think the overarching idea is that these younger patients should be considered for clinical trials of early intervention and treatment that perhaps might improve their outcome and their overall survival, and eventually, reduce the excess mortality that's associated with MPNs.